Good afternoon, everyone. Welcome to today's SVS VQI Updates and Registry Revision webinar. My name is Jennifer Correa. I'm the Marketing Manager at the SVS PSO. Today, I'm joined by our presenter, Carolyn Morgan, SVS PSO Director of Clinical Operations, as well as other members of our PSO team. Before I turn things over to Carolyn, I do just want to go over a few brief housekeeping items. We will be keeping all lines muted throughout today's presentation, but we do encourage you to type any questions you may have in the Zoom Q&A box. This will allow us the opportunity to answer questions as time allows at the end of today's presentation. In the event that we are not able to answer your question live during the session, we will reach out to you via email following the webinar. And with that, I'll turn things over to you, Carolyn.
Hi, Jen, thanks, Jen. Hi, everybody, and welcome for joining. Today, we're just going to review some of the VQI updates and some of the registry revisions. The first thing we're going to speak to, we have Katie Sullivan, who has joined us. She's going to be reviewing the physician reporting. We're going to be talking about, again, the registry revisions, and then I have some updates that I just want to share with everybody. So with that, Katie, I'll let you take over.
All right, perfect. Thank you, Carolyn. I'm Katie Sullivan. I'm a senior statistician with the PSO. And so I just wanted to give a little refresher on our new physician reporting, what's included in the reports and what our plan is with them going forward. So the physician reports are going out or should have gone out early this week, and they are sent to the physicians in their pathway share file. And the physicians receive their own individual reports in their accounts, and then any hospital managers will receive a sample report once their physicians receive a report. So the report includes physician level results with center and VQI benchmarks, and centers must have at least 3 physicians, and physicians must have at least 10 cases in order to appear in the comparative figures. So it's very similar to our regional reports, just instead of centers and regions, it's physicians and centers or cases. And physicians can access their detailed case information similar to the regional reports in a drill down appendix. So this includes only their cases at a particular center. So if a physician has multiple centers, I do want to note they will receive separate reports for each center. And this report for this year, we're starting out with a small subset of our overall regional reporting metrics to be expanded in future cycles based on feedback from these first couple releases. So the metrics that are currently included are pre-op smoking for all of the registries shown here, and then also a couple other registry-specific metrics for CEA, length of stay, and PVI, claudication, ABI, and toe pressure. And so this is an example of that sample report that hospital managers will be receiving. So you can see what the structure will look like. So it'll have an individual physician's results in the Your Results column, and then comparative results for their center and VQI overall for each metric. And then after the table, you'll have the over 4-year time frame plot shown here with the physician results, and then also center and VQI. And then finally, for each metric, we'll have the comparative chart that compares an individual physician's results highlighted in orange to the other physicians at their center. So that's an overview of what the report will look like. And as a reminder, these will be uploaded just to the accounts and pathways that are indicated as physician accounts. So happy to answer any questions. Yeah, thank you.
I'm not seeing any questions, Katie.
Well, if anything comes up, feel free to type it in at any time. With that, we'll just move along here. I wanted to let everybody know, not everybody's in the TVAR registry, but there were some revisions to the TVAR complex EVAR registry. This is related, this first change is related to the change in workflow that was discussed and reviewed during VQI at BAM. In the past, all staged procedures were included under the index procedure, but it was identified that it was very hard for data managers to truly know what is the index procedure. So the TVAR committee elected to have all stage procedures, aortic staged procedures, entered separately. So with that, this staged aortic treatment dropdown needed to be revised. So it is now revised to no stage 1, stage 2, or stage 3. We recognize that there may be times that stage 1 was done outside of your facility. So you really are doing stage 2. So we just ask that you select stage 2 and then in the comment box, just jot down a real quick comment that stage 1 was done outside of my facility. And remember that stages include any aortic treatment for the aortic pathology done before the first procedure. TVARs performed in the same OR date as a type A repair should be excluded, and TVARs report performed for type A repair on a separate day should be included, even if done during the same admission. The next thing that we wanted to share, many of you I know are aware that in the abdominal space in the past, we were only collecting data on treatment to your SMA celiac left and right renals. But a lot of our facilities are starting to expand and do additional treatments to additional vessels. So the committee requested that we add 2 additional branch fields. What will happen is when you open up your TVAR form, you will be asked, were there any additional branches treated? And then you would select either 1 or 2. And depending on what your selection is, then the additional branch treatments will open up. The additional branches included within these drop downs are your hepatic, IMA, renal accessory left, renal accessory right, splenic, or other. We have built some dependencies into these fields so that if additional branch 1 equals hepatic, hepatic cannot be selected for additional branch 2. If there is an accessory hepatic, it is advised that you select other, and then in the comment box say accessory hepatic. I don't even know if there is such a thing, but I'm just trying to be all inclusive. So then when you go into your treatment tab, you will be asked, what was the status of the additional branch prior to treatment? What was the treatment type? And what was the post status? So you'll see here we have additional branch 1, and you can select either the branch was patent, stenosed, or occluded. Under branch 2, if you say there was a treatment and it was a fenestration treatment, an additional drop-down box will open and you will be prompted to select whether it was manufactured. Was it physician made on the back table, or was it physician made in situ? Another new feature for the TVAR complex EVAR is there are some new aortic grafts available on the market that you can do CO2 flushing instead of your saline, heparinized saline flushing. So the theory is it's that flushing that with CO2, which is denser than air, helps to displace any remaining air that might be within the device and minimize air emboli, thereby reducing the risk to the patient. And so it is just a no or yes select option, and this will open up for every aortic device that is entered. So for our help text revisions, this is the first help text revision for our smoking cessation. I wanted to make sure that people were aware that when we talk about smoking cessation counseling, it is smoking cessation counseling and or prescriptions, RX, treatment. We've done our best. I've had multiple eyes on this, but I found one today that was missing, and I'll go through and fix it yet again. But I just wanted to remind people this particular variable is a single select variable. And there may be times when there is documentation in the medical record that the patient declined preoperative smoking cessation counseling or treatment, but there was additional documentation that preoperative counseling/treatment was provided despite the patient declining. You can abstract patient decline, or you can just abstract, yes, it was given. I always want to give credit to the person that gave the counseling, whether you select or abstract, I should say, patient declined, or yes, smoking cessation counseling treatment was provided, you will get credit no matter what. I just always lean toward giving credit to the person that took the time to do the counseling. An update to the definition for interventional team. It is any formal smoking cessation counseling conversation provided by any team member, regardless of level of education or clinical experience, involved in the care of the patient. Ideally, and this is ideally, but we just wanted to make sure it was documented, it would be a formal conversation. Everybody knows that it's not going to say there was a formal conversation that lasted 3 minutes. But we wanted to make sure that during education, and it is written down, that this is the ideal scenario. So it'd be a conversation lasting 3 minutes or longer. And it's not just handing a piece of paper or a pamphlet to a patient saying, you need to quit smoking, read this. If there is documentation of smoking cessation conversation, but it is not known if it was a formal conversation, we still advise that you abstract type of smoking cessation counseling as interventional team, along with the other applicable counseling types. There are some centers that ask patients to sign a condition of admission and treatment form, which is just a form that has a blanket statement in there that they received smoking cessation. They had a conversation, and this is accepted as to be abstracted as interventional team. And as you can see, there were a lot of and ors added throughout the help text. I did not, during this, for the purposes of this webinar, include every single help text update, but I did cherry pick some of the ones that I thought were bigger and of more importance. The next help text update is the definition for COPD has been revised. We found during some of our source data audits that if there is a mention of emphysema or bronchitis or asthma in the medical record, people were blanketly abstracting COPD. We just want to remind everybody that these types of diagnoses need to be diagnosed and documented in the medical record by a physician, a nurse practitioner, a physician assistant. It needs to be documented. It is discouraged that assumptions are made regarding a diagnosis based on description. So chronic obstructive pulmonary disease, abbreviated COPD, is a progressive lung disease characterized by ongoing inflammation and damage to the airways and air sacs of the lungs. And then the damage leads to airflow obstruction and breathing difficulties. The next help text update is the update to congestive heart failure. We want to make sure that when people are documenting congestive heart failure, they are documenting the worst or most severe class of congestive heart failure found in the electronic health record or electronic medical record. And we try when there is availability to provide source documentation. You can see in this definition, it talks about SNOMED codes. And I just wanted to add to the help text the link to the most recent American Heart Association document that came out this year, and it supports all of these definitions. So we have some new interactive dashboards being released next week. One is for the hemodialysis access. The next one is for your lower extremity amputation, and then IVC filter. I do want to call out that we are piloting doing some additional drill down fields for the lower extremity amputation registry, or excuse me, interactive dashboard. And as you can see down below, it's small to start, but we want to get some feedback to see what people think. So within the drill down, you will have your PrimProc ID that if you want to get the full details, you can open that up and get it. But we're also providing the number of limbs treated during the procedure, the amputation type, and the amputation count. Just a reminder, within Pathways, the analytics and reporting engine used to be available on a tab on the landing page of Pathways when you log into your Pathways account. Now it is located, when you log into your landing page within Pathways, when you look to the far right-hand side, you'll see the tabs that you can see illustrated at the top of the screen here. If you click on Reporting, it will open up a left navigation, and then you click on your Analytics and Reporting engine. I just want to call out the Support tab that's on the far right. We are renaming what used to be called blinded data sets for our researchers to de-identified data sets. These are now going to be available on the Pathways platform. If you navigate over on your Pathways landing page to the Support tab, once the Support tab opens, you will see a drop-down list, and if you click on Resources, you will see a drop-down data dictionary. Now, this hasn't even gone into demo yet, so I couldn't get any screenshots for you. But when you click on the data dictionary, I believe you're going to see two selections. Your Registry Abstraction Data Dictionary, which is a data dictionary all of you are familiar with, that we use to abstract our cases for each of the registries. The second data dictionary available is your de-identified data dictionary. The reason why we're providing that is sometimes our researchers aren't aware of what variables are available when they have an idea for a research project. So this way they'll be able to open up the data dictionary and be able to see what the available variables are. Why are some of the variables available in the clinical and not the de-identified? The de-identified data dictionaries are used for research purposes. They provide a list of procedures over who knows how many years. And because we are a patient safety organization, the de-identified data dictionaries cannot provide date of births, procedure dates, zip codes. We can't provide device information, specific device information. We can't provide specific medication information. So this helps our researchers, and I'm going to show you something that might help you as well. If you look down here, this is example of the columns that are available within the de-identified data dictionary, you'll be able to see the date the variable was last modified. When was it last changed? Maybe, as you recall, not too long ago, we updated our antiplatelet medications for pre-op, post-op, and long-term follow-up. That was a modification. So for all of those, for that variable, you will see a modification date. You can see when the variable was introduced, and you can see when variables were retired. So this might be an additional resource that might help all of you. There is a new device out for carotid artery stent, and I thought it would be important for me to share with you. It is a 3-in-1 device. It has embolic protection, it has a self-expanding stent, and a post-dilation balloon all on one catheter. So I just wanted to make sure that you all are aware of it. This device, if it is used, it will be captured within the device details for the carotid artery stent, but we will also be listing it under the embolic protection type, just as NeuroGuard IEP system. There will not be any device details regarding size or length of the device. It will just indicate that the NeuroGuard system was the system used for embolic protection. So we've been having a lot of conversation about preoperative aspirin. I just want to start out by saying that the intent of collecting preoperative medications within all of our registries, the intent is to capture or get a picture of what the patient takes on a daily basis at home. Aspirin just is a little bit different. We had an extended conversation yesterday with leadership, and this is why the definition for aspirin is slightly different than, not slightly, it is different than the definitions for the other medications. The definition for aspirin specifically states if aspirin was taken preoperatively within 36 hours of the surgery, and it should say /procedure, but I'll get caught up one day maybe. Preoperative is defined as the start of anesthesia or incision time, whichever comes first. And just know that combination drugs such as Agonox or the old-fashioned Persantine, that is included as an aspirin product. This variable includes any dosages given before the start of anesthesia, whether it is a loading dose or a supplemental dose. Now, I will warn you and admit that within some of the registries, because this was tied to an industry project when we were looking at rivaroxaban, there will be drop downs asking what is the aspirin daily dose. Now, this is the total daily dose. This is the dose that the patient takes on a daily basis. This is where you will see this is not preloading or supplemental doses. If a patient is admitted into the hospital with no prior diagnosis, and I'm just making this up, there are going to be all different kinds of scenarios, but just as an example, a patient is admitted into the hospital to have their gallbladder taken out. Because they're 72 years old, they decide to do a stress test, or they decide to do, I don't know, carotid ultrasound. And they realize the patient has atherosclerosis. The patient then is loaded with aspirin prior to going into a procedure either for the CEA or CAS. The recommendation is that you leave the ASA daily dose blank, because the patient hasn't been on a daily dose. We just know that the patient did receive aspirin within 36 hours of surgery. This is confusing, but aspirin is so important for our patients that have stents and balloon angioplasties or any kind of drug-eluting device that is placed. I want to do a quick review of the Rutherford classification. So within our PVI, our infrainguinal, and our superinguinal, we request what we call in the registries patient symptoms. Those drop downs are directly tied to the Rutherford classification. This was a decision that was made at the time by the PVI committee, the infrainguinal committee, and the superinguinal committee. There were gradings of 0 through 6 for the severity of peripheral artery disease, abbreviated PAD, and acute limb ischemia, or this is an old document that I just copied and pasted, is ALI, and is based on the symptoms, objective findings like ABI and Doppler, and the extent of tissue loss. It ranges from symptomatic to major tissue loss and gangrene. These are part of the copywritten Rutherford classification. The reason why there is a copywritten or a classification system, much like the TASC and GLASS classification system, it provides a framework for clinical decision-making, treatment planning, and consistent communication amongst healthcare professionals. So I'm going to show you 3 different examples of definitions of these different classifications, and I'm going to primarily focus on your grades 1, 2, and 3. So grade 0 is called asymptomatic, no hemodynamically significant occlusive disease. And according to this published document, normal treadmill or reactive hyperemia test. Now, as data managers, we know I should not say never, but very rarely are you going to see those terms dictated in the medical record. Mild claudication, it means that they complete the treadmill exercise after greater than 50 millimeters of mercury, and then they did some recordings of measurements. And after exercise, your readings were greater than 50 or less than 20 at rest. And then it goes through. The next definition talks about stage 0 being asymptomatic or no PAD symptoms. It talks about mild claudication for stage 1, moderate claudication for stage 2, and stage 3 being severe claudication. The mild, moderate, and severe claudication is not specifically defined within the Rutherford classification, but it is measured in the Fontaine, which I'm going to show you in a few minutes. This is tricky. I will tell you that Melissa is working on the source data audit right now. We are collecting the leg symptoms, whether it's stage 1, 2, or 3, or I think we have in the registry, I know, mild, moderate, or severe. And this will be the PSO's opportunity to collect objective data to take back to the physicians to help us with better definitions. Stage 4 is rest pain, meaning the patient has rest when they're at rest, sitting in a chair or sleeping at night. Stage 5 is ischemic ulceration, not exceeding the toes. And then stage 6 is frank ulcers or gangrene above the toes. This is an example of the Fontaine. And so you can see in here that it says mild claudication is pain or cramping with exercise that is relieved by rest. But how far is the exercise? Is it walking around Home Depot or a super Walmart? but they did define it talking about walking a distance of more than 200 meters. I have to be honest, I used to be a data manager, and I can honestly say I never saw the distance that a patient could walk before they started having pain. It was always more in a easier understanding. They could walk to the mailbox. They can't walk around the grocery store, things like that. So these are just different examples. We've had a lot of questions about what does asymptomatic mean? It means that the patient doesn't have any symptoms of peripheral artery disease. And I'm making this effort to educate you as data managers, and hopefully then this can be passed on to your physicians at your centers so that when they can do their dictation, you will have a little bit better understanding of the leg symptoms that the patient is experiencing. And with that, we'll open it up for questions.
Okay, so we're gonna start with, we have a first question about the stage aortic procedures, and can you have two TVAR forms for the same patient? I don't want to get in the specific details of what's listed, but overall, big picture, can you have two TVAR forms for the same patient?
You can have two separate TVAR entries for the same patient, but it would have a different prim-proc number, and unless it was two different OR visits, you would have two separate forms. You would not have two forms for the same operating room visit.
Correct. And then we have quite a few thank yous, and one of the thank yous was for the changes to TVAR. So we're really excited.
Oh,
Now
good. But it's a lot. I mean, it never ends, you guys, and I'm so sorry, but I'm just trying to keep the registry relevant.
Okay, so all of the next few questions are pertaining to smoking cessation. So who is the interventional team? Is it just the surgeon and his group, or can it be the PCP?
It can be the PCP. It could be a pharmacist. It could be, in some of our Catholic hospitals, the chaplains go around and do smoking cessation counseling. If it is documented in the medical record that someone and a chaplain is involved in the patient's care, they're spiritually involved in the patient's care. So it can be anybody that is involved in the patient's care.
So, and then the next question was, can an anesthesiologist give it? And the answer would be yes, anyone involved in the patient's care. And then there is a question that I'm going to ask that someone, it's about Wellbutrin, and if it's for depression or smoking, and how can you tell? Please reach out to 50 support with the specific information, and they can tell you how to abstract that.
Well, the other
go ahead.
part, I'm sorry, just the other thing though, if you were questioning, if you see that the patient has Wellbutrin on their discharge medications or even on their pre-op medications, it would not be inappropriate for you to reach out to someone who is caring for the patient and say,
yeah, why is this?
why
are
is
they
this being prescribed?
Absolutely. Smoking cessation discharge instructions are provided, and it has 1-800-QUIT NOW. Does this count as smoking cessation counseling?
Yes.
Okay. If an RN provides it, can they answer yes?
Yes. If a
Okay.
medical assistant provides it, you can answer yes.
So here is a question. I believe this has to do with COPD, and they may have to reach out to 50 support. It just says, what about a diagnosis from a CT scan? And I believe that's about COPD, but I'm not 100% sure. So either if you could please
If
put more information in the chat to me, because I don't know if it was about heart failure, which was right afterwards.
So what we recommend is, at least in the electronic medical records I've been associated with, and I think the majority of our physicians have some type of electronic medical record, there is typically a problem list or a list of diagnoses. And this is where that would be my first place to check to see if there was a diagnosis of heart failure or COPD. If you see a diagnosis of COPD from imaging, again, it is the recommendation of the PSO to reach out to the provider or someone that is taking care of the patient and say, do you agree? I mean, I can't tell you how many times I used to see, at least post-operatively, that patients after having a CEA or CAS would go have a CT scan of their head because they had something that was questionable going on, and the imaging report said the patient had a stroke. But the treating physician said, no, they didn't. So I always recommend, if there is conflicting information or if it is not documented by the physician or someone working with the physician, that the question be asked. That way we know we have clean data.
So we have several examples about COPD and not the best documentation. Maybe they have emphysema, maybe they have some other diagnosis. So just to reiterate what you said, if there's a question about it, please reach out to someone and ask if they have COPD, but you need a diagnosis of COPD to assign that element. There's a couple of these with very specific kind of questions. Are we going to get a copy of this presentation?
Absolutely. If you go on to vqi.org and you log into the members only tab, there will be the slides available as well as the recording of this webinar. And I want to thank Jen Correa because we have a number of registry revision webinars, and it's hard for even me to remember which webinar I talked about what. So Jen provides now a quick breakdown. It might not list every single thing, but it'll give a high-level overview of what was presented during this presentation and past presentations. We didn't go retrospectively back years, but we started this a few months ago.
So several people are really thanking you for all your work and that they feel heard that you've made these changes. So I really want to get that out there. Then there's a question about CHF classifications, and if there's no current there's no documentation on their current stage of CHF, what documentation what class stage should they document? And for that, because there's specific information, please reach out to Pathways Support so they can get the information that's actually in your chart and give you the appropriate guidance. So here's a question about aspirin. So to clarify, if a loading or supplemental dose of aspirin was given preoperatively, leave the dose in the pre-op section blank.
So
The daily dose.
this is kind of the crazy thing about this. So we have patients, we've all seen patients, they're on 80 milligrams of aspirin every day. They come in to have their carotid procedure, and then they give them a loading dose. The answer to the daily aspirin dose would be 81 milligrams. But then we have the patients that come in that are newly diagnosed, and they've never been on aspirin at home. Those are the scenarios where I recommend that you just leave the daily dose question blank.
Yeah. So then the Rutherford score, I believe this is what this question is pertaining to. Is the Rutherford score in meters? Carolyn, did you say meters?
Yes. Well, that's the Fontaine to be,
Yeah.
to be perfectly granular.
So people want to know why it's in meters and not feet, and that's the people who wrote it. We did
That's
not
right.
we did not write it. whoever wrote it, that's how they developed it and what people have accepted as the standard.
And I will tell you that Fontaine isn't used that much anymore. But it is still around. There's still, references to it in current publications. So that's why I just wanted to share it with you, trying to be, fully transparent and provide you all with as much information as possible.
Absolutely. So now we're going back to smoking cessation, and there is some confusion because for a while we had a slightly different definition, and now we are very much expanding it, and people just want to confirm anyone, including a pharmacist, a PCP, anyone who's assisting in the care of the patient can provide it.
That is absolutely correct.
So
100% correct.
we understand that this is a slight change when there was a lot of feedback from data managers that really trying to figure out who was a member of the interventional team was really becoming such a burden, and that was not the intent of the committee at all. When they did that, they thought they were making it easier. So they really, I want to let everyone know, like, we hear you. This is a change from what it was, and it is expanded. So if there is documentation, it is abstracted as such. So then there's a question about antiplatelet and statins also have the same definition taken with 36 hours of the procedure on the help text, but what you spoke about is only for aspirin.
I need to get back to leadership and ask them what we want to do with the 36 hours for statin and antiplatelets.
Yes.
So I
But
don't have an
currently-
answer. Just
yeah.
keep on doing what you've been doing.
And that's it for the questions.
So the intent of especially the statins and antiplatelets, as you know, the clopidogrel, Plavix, your chronic anticoagulants, your statins, the intent of the variable, and we reached out to Jack Cronenwet because this definition has been around longer than I've been with SVS. And so I specifically asked him, how do I educate and support our data managers to help them? And he said the intent is to determine if the medication is on board or circulating within the system to the best of your knowledge at the time of the procedure or surgery. That's the intent. And so I brought up, I said, well, what if someone took their Plavix the morning before at 7 a.m. They were scheduled for a 5 p.m. and 5 p.m. Surgery. It gets canceled. They're put on the next day. That's 48 hours. Well, and he goes, the intent. It's the intent, Carolyn. I said, but how do I educate people? How do I help support them? And so that's why I clarified the aspirin, and now I will go back to leadership and ask them how they want me to better define the statins and antiplatelets.
And then we had, Katie's answering. We had a physician report question. What was the exact name? And Katie is typing the answer in now.
Yeah, I'll also just say it. The exact name will be Fall 2025 Physician Quality Report, and that'll be the name under the Pathways share file.
And then we have more thank yous.
Well, I thank you guys because I really, I'm listening to you. I wish I could get things done faster. I wish I could meet everybody's expectations, and I'm trying, but we'll get there. We'll get there as a team. I am your advocate. I will continue to advocate for you and share your concerns. We've had a couple people reaching out with some specific questions about adding variables to the registries, and I need to get back to these people, but I can tell you that I took it to leadership yesterday and they were like, we're adding more variables. That's already covered here and that's already covered there. And they gave me some suggestions to take back to these data managers to help them meet the goals that they want with these additional variables. So I am sharing, and we're going to continue forging on. I am going to put a plea out again this year. I'm already collecting case scenarios for VQI at VAM next year. I envision, and I have buy-in from both leadership and our committees. I think we're going to do something like a case presentation or a grand rounds, and we're going to have our physicians actually potentially showing you images and showing them blowing up balloons or showing what a dissection looks like or things like that. And then sprinkled within that presentation, we'll add case scenarios. How would you abstract that? How would you do this? How would you do that? And hopefully we're also going to include complications. So that's the vision. We'll see how it goes.
And then just some more thank yous. I think everyone's very appreciative of a lot of these updates.
Well, you're so welcome, and we'll keep making it better, everybody. I don't know that we're going to have another webinar before Thanksgiving. I am trying to bundle more of my registry revisions together so that there aren't so many frequent changes. Now, obviously, you all know that sometimes there's a fire alarm and we got to get it done sooner. But if I don't talk to you all, or if you don't reach out and we have a short conversation, I hope everybody has a great fall and a happy Thanksgiving.
All right, everyone have a good day.
Thank you.